This is a 18-year-old male with a history of jaw deformities and facial asymmetry. He has oral-palatal-digital syndrome with a history of a cleft palate. And you can see he has assisted hearing as well. Frontal view shows several things, some facial asymmetry related to the globes and orbits. You can see that this eye is lower than the left eye. The brows are a bit asymmetric as well. He has a nasal deformity with a reverse C-shaped deformity. The nasal tip is pretty significantly deviated over to the right side of his face, off-axis deviation with significant collapse on this right side. He has some facial asymmetry as well. The right cheek is narrower than the left. He has lip incompetence. You can see how the philtral columns are coming in this direction, whereas the nasal dorsum and tip is going to the opposite direction. His lips are asymmetric. You can get the appreciation that there's an open bite. His chin looks on with the radix and the glabella. He has ear asymmetry as well. Here on smiling, you can appreciate his maxillary midline is on basically with nasion and the chin. His mandibular midline is close to being on as well, but he does have this open bite. This is before orthodontic appliances to be in place. You can see some asymmetry with smiling with a deeper nasolabial fold on the left compared to the right. Difference in the smile line, again, the nasal deformity. Here on subnasal view, again, you can really appreciate the significant nasal deformity, which we will address in a future video. You can see how he has that open bite. Three-quarter view, again, nasal deformity. Recession of both the upper and lower jaw. He has a bit of a long chin and lower two-thirds of the face with what's called mentalis strain, where he has to really force the muscle to close the lips. Here on lateral view for both the left and right, you can see that he has a prominent radix, prominent nasal dorsum, prominent tip. The lip appears pulled back in this direction, whereas we would ideally like it to be curled out in this direction. Both jaws, you can appreciate, are back or recessed compared to the forehead or glabellar region. When we think of the zero meridian line or plane, this is also something that we think of in terms of a convex profile. Very short chin-throat distance. Menton and pagonion are back compared to the lower lip, whereas that should be better in line here. Occlusion, you can see that he has a narrow maxilla. His midlines are close to being coincident, but slightly off. He has an anterior open bite. He has a class 3 molar and canine malocclusion on both the left and the right-hand side with anterior cross bites. Very narrow transverse discrepancy again of the maxilla. Here's a cephalogram at the time showing, again, when you look at cephalometric numbers and we look at the SNA, SNB, and you look at the zero meridian line, how back the maxilla and mandible are compared to where they should be in space. The chin is long, the pagonion, menton are back too far compared to the teeth and the lip. This is all digitized, and this is after some degree of orthodontics in place pre-surgically, which has straightened the teeth, but sometimes can worsen the occlusion. Look here at how significantly deviated the nasal bones are compared to the chin. You can see that there's cross bites on the left and right side. It's worse here on the right. Midlines now are off more after pre-surgical orthodontics, very significantly discrepant AP as well as transversely as well. Here on lateral view, again, we're not really seeing the glabella here, but you can see the prominence of the nose and how far back the upper and lower jaw are compared to this on both sides. He has a very prominent anterior nasal spine, and this is going to be important that we preserve this when we're planning to do a rhinoplasty down the road as well. Here now we've done the three-dimensional plan. In this case, you can see the different colors in the maxilla. We've segmentalized and decided to do it just on the left-hand side to help with that posterior cross-bite and transverse vicinity. When we do the plan, we first correct the cant. You can see how it's come down more on the right than the left. We ensure that the midline's on. We check the yaw. We check the bodily position left and right. We then look at the mandible and put the mandible in the right place, sagittally as well as from a frontal view, and a genioplasty with a custom plate to ensure that the chin is shortened and centralized as it should be. Sometimes looking from below here too, we can change the yaw position of the chin. We want to make sure the TMJs are adequately seated and that we know the amount of advancement or setback to help with planning of the plates. At the time of this video, I did not use as much 3D plates of the maxilla. These days, I probably would have used a custom 3D plate here to really accurately and adequately reposition this. But at the time, mandible first, splints, and a custom plate at the chin, which works very well too. Here on lateral view, you can see now how things are lined up better. There's a positive overjet. There's been an advancement on the right. It's a class 2 molar simply because we're missing a premolar up top here, but the buccal lingual relationships are improved. Overbite overjet is improved, and that, you know, we've aligned this with that 0 meridian plane. And here shows additional images. Here you can look at the before and after occlusion, and the advantage really of 3D planning is you can do it almost like haptic feedback, where we can see both in the tongue vicinity as well as on the frontal view how these teeth are going to be lined up. And again, additional data so we know where the roots are for when we're segmentalizing it, seeing how we're impacting on one side, coming down and lengthening on the other side to correct the cant. Using these tools, we know exactly where the nerves are, where we make our cuts so that we avoid the nerves, where these lie relative to the teeth and the sagittal split as well. And with segmentation, even with custom plates now, I've been using a splint like this that is really well tolerated postoperatively and helps maintain the occlusion in its transverse position postoperatively. This shows the genioplasty, so there's a custom cutting guide where we pre-drill these holes and a plate that will really accurately reposition, especially in these asymmetric cases. For the BSSO, while we're here, you can see that there's an advancement here and more of a setback there. 3/4 view as well, showing that chin plan and position. Chin plan and position again. So post-operatively, you can see he has improvement in the areas that we've addressed. So in terms of the nose, we know that when there's deviation ahead of time, that's going to remain or persist, and we'll address the nose later. So there still is a bit of a reverse C shape. The other thing when the upper jaw comes forward is the alar base widens, which is done for him. The lip, though, you can see is much more symmetric and much more supported. You can see that the symmetry from Cupid's bow to the lateral portion of the commissure is much more even compared to pre-op. The lips are aligned better. Any canting has been improved. The lips are more competent and come together. The chin is more midline. We've done some fat grafting, which has helped fill in some of these areas of the cheeks and under lips as well. Here on lateral view, so some aspects of the nose actually improve, which we've shown in papers before, how the dorsum and dorsal hump appears less after maxillary advancement. The position of the subnasally to the tip usually appears less and turns up slightly. You can see that the E line and S planes are much improved too. When we draw the lines from the nasal tip through the lips and the chin, and there's a nice labiomental crease and much improved projection, much improved advancement, chin-throat definition as well. Here on the opposite side view, so he'll still need a rhinoplasty, of course, but you can see how this is the good foundation of the face by doing the upper jaw, lower jaw, chin, some fat grafting to set the stage. And as you noted in the video, we preserve the anterior nasal spine, so there's a good base on which we can do the rhinoplasty later. And this brings it all together. So this is just after the double jaw orthognathic surgery with genioplasty and fat grafting. You can see the improvement of his face, facial balance, based on moving the jaws which will improve both his occlusion, his airway, his symmetry, and his aesthetics. At this point, you can see he has off-axis nasal deviation with a reverse C-shaped deformity. The nasal tip is to the left of both the Cupid's bow as well as the radix in the chin. His alar base is a bit widened, more on the right than the left, with this length of the ala and alar retraction on the right being greater. That's consistent with the tip deviation. You can see the mid-vault is pushed in and collapsed more on the right. And this is just to remind you from the earlier video how his nose has changed or his face has changed between now and jaw surgery. So he already had this reverse C shape. He had a broader tip that had less wideness, and after jaw surgery, the C-shaped deformity actually doesn't look as severe, although the wideness is now greater, and the tip is not any more refined, but it is slightly turned up in the lip, and the overall face obviously looks better from the jaw surgery. So this is why we do jaw surgery first and rhinoplasty second. Here on smiling, you can see he has a bit of zygomaticus and risorius pull of the ala. You can still appreciate that reverse C-shaped deformity, some infralobular plunge and or elevation at the subnasal component of the lip. Subnasal view or basilar view, you can see the width. Again, this nostril is more wide and horizontal compared to this one. This ala appears longer, and a lot of this is because the tip and the lower component of the nose is over to his left compared to the midline at the radix, the Cupid's bow, and the chin. So this needs to be moved over, and that'll help equalize these nostrils as well as moving the columella slightly over to his right. From a bird's eye type view, again, off-axis deviation, collapse on this side, more upright bones here on the side that it's deviated towards. Can see a little bit of shadowing, cephalic malposition of the lateral crus as well. Three-quarter view, low radix or narrow radix rather, a hook of the nasal dorsum and tip. Lateral view is glabella and radix almost blend, so the nasofrontal angle is somewhat shallow. This lip nasolabial angle is quite good at this point though. And again, just as a reminder, you can see that orthognathic surgery with counterclockwise movement makes it so the hump is less appreciable because this lower 2/3 comes further forward. It's turned up the tip some and given a little bit better definition, narrowed this dimension from subnasally to tip. And that's from orthognathic only. So again, setting the stage for the rhinoplasty here today. Three-quarter on the opposite view. Lateral in the opposite view, still a hump, still a bit of overprojection, still needs more of a carved out radix. So we saw in this procedure that we had to tackle this deviation from many vantage points. When you look at the bone and bony vault, these vertical bones on the left needed to collapse and become more horizontal. These bones on the right needed to stand up some, and the whole base needed to move over to the right-hand side. Sometimes we have to free up the bone in this vicinity as well. We use both auto spreader flaps, but also a thicker spreader graft on the right-hand side to help pull this over. Judicious cephalic trim, septal extension graft over on the right-hand side with some trim of the caudal septum so that we could move that whole base over. And again, the anterior nasal spine was preserved from the time of orthognathic surgery. We adjusted the medial crural feet somewhat. We placed articulated rim grafts, and in the end we did not need to do weir or sill excisions because by stepping this up as a tripod, it was able to narrow the alar base on its own. We finished with some fat graft and crushed cartilage overlying the dorsum to really smooth and blend that area. And now you can see on frontal view how improved this is. You can see a clearer light reflex that appears straight. No longer is there a significant shadow going this way, but the whole nose looks much, much straighter. You can see this nice diamond at the tip for tip definition. The infralobule has been brought up and defined nicely. There's a nice shadow and light reflex at the ala. The alar base has been narrowed some, again, just by the tripod component. Here on 3/4 view, again, you can see that improvement of the tip, the diamond appearing tip, a nice light reflex at the ala. Right lateral view, you can see how the dorsum is nicely straightened, the tip is projected, nice nasolabial angle, good definition of the ala to columella, really improves this overall lip balance as well. Here on 3/4 view, again, a much straighter nose, and we're looking a lot at these light reflexes and shadows to ensure that good balance is achieved. Here on left lateral as well, turned up the nasolabial angle, improved tip projection, and this all lies in with the simulation that we performed with him pre-op. And just to show how things have changed, this far picture is before any jaw surgery, before that video number 2. This is after jaw surgery only, where you can see there's already a little bit of nasal improvement. It's already turned this up some because of the repositioning of the maxilla. The hump looks smaller. The tip looks less projected. And then after rhinoplasty as well, we were able to really balance that even further, putting this in balance with his face. 3D rotating view brings it together, where that over-projected off-axis deviation, reverse C-shaped deformity is improved. The tip is brought up into a better balance and position. The alar base is narrowed appropriately. There's a nice diamond tip definition. In zooming in, you can see that the overall balance from his rhinoplasty. So thanks for listening. If you have any other questions, please check us out on our website, www.dereksteinbacher.com.
Thanks again.